Welcome to Online Anesthesia Video of the Week. Today topic is presented by Dr. APARNA JAYARAJ MD, PDFNB, Senior Registrar, Ganga Hospital Coimbatore. Her achievements are: awarded first prize in short case presentation on difficult airway management in ISA East Zone PG Assembly at SCB Medical College Cuttack in 2018. Awarded second prize in World Anesthesia Day Quiz competition organized by ISA Bhubaneswar chapter in 2019. Won second place in Regional Anesthesia Quiz Competition, AORA 2023. She has so far published 3 papers.
Good morning, everyone. I'm Dr. Aparna, Senior Registrar at Ganga Medical Center, Coimbatore. Today, we're going to discuss about the PNS guided lower extremity blocks. Before we go into the topic proper, the innervation to the lower limbs are provided from the lumbosacral plexus. The major nerves innervating the lower limbs include the femoral nerve, the lateral femoral cutaneous nerve, obturator nerve, and the sciatic nerve. Coming to some basics of anatomy, the femoral nerve arises from the posterior division of the anterior primary rami of L2 to L4. It exits the lateral border of the psoas muscle, enters the femoral triangle behind the inguinal ligament, and then lies on the anteromedial surface of the iliopsoas muscle. As you can see, from skin down, there is skin, subcutaneous tissue, there's fascia lata, then there's fascia iliaca, and below that is the femoral nerve. It is important to notice the relationship of the femoral nerve along the vascular structures in the inguinal region. From medial to lateral, there is femoral vein, femoral artery, and the femoral nerve. That is commonly known as the Van arrangement. The indications for femoral nerve block include analgesia for the neck of femur fractures, proximal femur surgeries, shaft of femur fractures, superficial surgeries over the anteromedial thigh or medial leg like skin grafting, saphenous nerve stripping, quadriceps tendon or muscle biopsy, analgesia for total knee replacements, and sciatic nerve blocks for complete anesthesia of the lower limbs. Distribution of anesthesia includes anesthesia over the anterior and medial thigh down to and including the knee, articular branches to hip and knee joint, and motor to anterior compartment muscles. Equipment that you need to perform the block includes the sterile towels and gauze bags, a syringe with the local anesthetic. If you're using it for a surgical anesthesia, then levobupivacaine or bupivacaine 0.5% or bupivacaine 0.5 to 0.75% are usually used. For postoperative analgesia, you can use slightly lesser concentrations of the drug, like 0.2 ropin or 0.25 bupivacaine. Around 50 to 20 ml of local anesthetic is required. A 25 gauge 1.5-inch needle is used for skin infiltration, and a 5 cm short beveled insulated stimulating needle is used to perform the block. A peripheral nerve stimulator and a surface electrode is required. The patient is kept in supine position with the ipsilateral extremity abducted to 10 to 20 degrees and slightly externally rotated. The site of needle insertion is located at the femoral crease, which is a prominent anatomical landmark. But to form the inguinal ligament, a line is drawn from the pubic tubercle to the anterior superior iliac spine. Along the line, the femoral artery is palpated and the insertion point is immediately lateral around 1 centimeter to the pulse of the femoral artery at the femoral crease. Under all aseptic precautions, local anesthetic is infiltrated subcutaneously at the estimated site of needle insertion. The needle is connected to a nerve stimulator set at a current of 1 to 1.5 milliampere. Entry is 1 centimeter lateral to the femoral artery, and the needle is introduced at 30 to 45 degree angle to the skin in a Teflon direction. The needle is advanced to pop the fascia lata and the fascia iliaca. As the quadricep muscle contractions are elicited, the current is gradually decreased while the needle is advanced. The position of the needle is adequate when the patellar twitches are elicited with a current between 0.2 to 0.5 milliampere. After negative aspiration, 15 to 20 ml of local anesthetic is injected. Let's see a video of a femoral nerve block performed. As you can see, the needle is inserted lateral to the femoral artery and the initial current is around 1.5. We look for the twitches of the quadricep muscles and you can see the patellar twitches. Now, once the desired response is seen, the current is reduced to elicit the response at 0.3 to 0.5. And you have to make sure that the response is gone when the current is less than 0.3, because that indicates intraneural placement of the drug or the needle tip. Coming to the assessment of the block, the sensory assessment is done with a cold or pinprick test on the anterior and medial aspect of the thigh and on the medial aspect of the lower leg for saphenous nerve. Motor blockade is assessed by asking the patient to extend the knee. The first sign of onset of the block is a loss of sensation in the skin over the medial aspect of the leg. Some common troubleshooting methods: if you don't see any response, that means the needle is far away from the landmarks, so re-examine the landmarks, reassess and reinsert the needle. If you contact the bone, it can be hitting the hip or the femur or the superior pubic lamina. That means the needle is too deep. You withdraw the needle and repeat the procedure. If you see a local twitch, it is usually due to the direct stimulation of the iliopsoas or the pectineus muscle. That means the needle is too deep and too cranial. So you withdraw, reassess the landmark and repeat the procedure. If you see a twitch of the sartorius muscle, that means only the branch to the sartorius is stimulated. The needle tip might be slightly anterior and medial to the main trunk. So you redirect slightly laterally and deeper. If you see a patellar twitch, that is the most ideal response, and go ahead with the injection. The complications include infection, hematoma, vascular injury, and nerve injury. Coming to sciatic nerve originates from both anterior and posterior divisions of the anterior primary rami of L4 through S3. It exits the pelvis through greater sciatic foramen inferior to the piriformis, and in the gluteal area, it has a horizontal course. As it enters the posterior compartment of the thigh, the most superficial part is the infragluteal region. There it lies between the two heads of the biceps femoris, and then it proceeds to travel vertically along the posterior aspect of the thigh. The distribution of anesthesia includes the posterior compartment of thigh, posterior aspect of the knee, entire lower limb below the knee with both motor and sensory except for the saphenous nerve territory. The skin of the posterior aspect of the thigh is supplied by the posterior cutaneous nerve of thigh, which is also a branch of sacral plexus. Indications for sciatic nerve block include lower limb surgeries when combined with femoral or psoas compartment block. For a distal surgery of the lower extremities, the distal approaches to the sciatic nerve block can be used, such as popliteal sciatic. Contraindications include infections and bed sores at the site of insertion, coagulopathy, pre-existing central or peripheral nervous system disorders, and allergy to local anesthetics. There are multiple approaches to block the sciatic nerve. So it can be blocked right from where it exits the pelvis till its bifurcation into the common peroneal and the tibial nerve. So the most proximal approach to the sciatic nerve blocks is the Mansour's parasacral approach or the sacral plexus block. Here, a line is drawn between the midpoints of posterior superior iliac spine and IT. The point of insertion is 6 centimeters along this line from the PSIs. The next comes the Labart's approach. In Labart's approach, the patient is kept in lateral decubitus position again, and a line is drawn between the greater trochanter and the posterior superior iliac spine. At the midpoint of this line, a second perpendicular line is drawn downwards for about 4 centimeters, and that marks the needle insertion point. Vinny modified this Labart's technique in 1975, and here what he did was he added another line, a second line from the greater trochanter to the sacral hiatus, and another line is drawn from the midpoint of the first line to intersect the second line, and this point of intersection is used as the needle insertion point. Next, there is Raj's approach, which is in which the patient is kept in a lithotomy position. The leg is flexed at the hip and the knee joints, and the GT and IT are palpated. And there's a line drawn between the greater trochanter and the ischial tuberosity, and the midpoint marks the point of needle insertion. Beck described an anterior approach to the sciatic nerve block. Here, the patient is kept in supine position, and a line is drawn from the anterior superior iliac spine to the pubic tuberosity. A second line is drawn parallel to the first line from the greater trochanter. And from the midpoint of the first line, a perpendicular line is drawn to meet the second line, and this intersection is used as the point of needle insertion. The problem with anterior approach to sciatic nerve is that it is a very deep block and it is difficult to perform technically. Coming to the Vinny's approach, as we said, the patient is kept in lateral decubitus position with the side to be blocked upwards. The foot on the side to be blocked should be positioned over the dependent leg. The landmarks that need to be marked are the greater trochanter, the posterior superior iliac spine, and the sacral hiatus. So a line is drawn between the GT and the PSIS, and another line is drawn from the GT to the sacral hiatus. And from the midpoint of the first line, a perpendicular line is drawn to meet the second line, which marks the point of insertion. This is usually roughly 5 centimeters long. So after skin disinfection, local anesthetic is infiltrated subcutaneously at the needle insertion point. And once the finger that palpates should be firmly pressed to the gluteus area to decrease the distance. The palpating finger should not be moved during the entire procedure because the movement of the muscles can cause the movement of the needle and the position can be changed. The needle is introduced perpendicular to the skin, and initially the nerve stimulator should be set to around 1.5 milliampere current. As the needle is advanced, first you see a gluteal muscle twitch, which which is just indicating the position is too shallow. You keep going on, and the gluteal twitches disappear, and brisk responses to the sciatic nerve starts. That is, the goal is to achieve a visible or palpable twitch of the hamstrings, the calf muscles, foot, or toes at 0.3 to 0.5 milliampere current. After you get the stimulus at the 1.5 milliampere, just gradually reduce the current till you see the response at 0.3 to 0.5 milliampere. This usually occurs at a depth of 5 to 8 centimeters, and after negative aspiration for blood, you can inject 15 to 20 ml of local anesthetic. Any resistance to the injection of local anesthetic should prompt the cessation of the injection and withdrawal of the needle by a few millimeters. A few troubleshooting tips. If the local twitches of the gluteus muscles are seen, that means it's direct stimulation of the gluteus muscle. You just need to advance the needle further. If the needle contacts a bone, but there is no twitch of gluteus muscles, that means the needle is near the attachment of the gluteus muscle to the iliac bone. That means your needle is too lateral. So you redirect the needle, reassess the landmass, and start again. Once the needle is encountering the bone, but sciatic twitches are still not elicited, that means you've missed the plane of sciatic nerve. Okay, that means the needle is either too lateral or too medial. You withdraw the needle and redirect. If the needle is placed deep, it is not hitting the bone, nor are you getting any responses. That means the needle could have passed through the sciatic notch. That is too inferior placement of the needle and inferior placement of the needle. So withdraw the needle and redirect it more superiorly. If you get a hamstring twitch or the twitches of foot or toes, you can accept this response and move. Here, as you can see, these are the landmarks. The first one is the GT and the PSIS and the line drawn from the midpoint, which is for the classic Labart's approach. The second picture shows for the Vinny's modification. Let's see a video. As you can see, the needle is inserted at the marked point, perpendicular to all planes. Initial current is 1.5. You keep going. See, initially you can see the gluteal twitches. Okay. Once you keep moving inside till you see twitches of the hamstrings and the toe movements. Once you see the movements of the toes, calf muscles, and the hamstrings, you can reduce the current. Okay. Coming to the popliteal sciatic approach, popliteal forces a diamond-shaped space that lies posterior to the knee joint at the lower part of the femur and the upper part of the tibia. It provides anesthesia to the lower limb below the knees, both sensory and motor, except for the saphenous nerve territory. So combined with the saphenous block, you can provide complete anesthesia for any surgeries that happens below the knee joint. Clinical indications include ankle fractures, toe reconstruction, tendinous repair, bunionectomy, below knee amputation, debridement of foot and leg below the knee. Contraindications include patient refusal, allergy to local anesthetics, infection at the site of injection, coagulopathy, and pre-existing neuropathy. The PNS guided popliteal fossa block can be performed by a posterior approach or a lateral approach. The posterior approach is usually there is a conventional prone position or lateral position, and then there's a supine position Rajas technique. In lateral approach, there's a Bloca's approach where the patient is in supine position. Landmark for the classic techniques are you have to palpate for the tendons of the semimembranosus, semitendinosus medially, tendon of biceps femoris laterally, and the popliteal crease below. This forms the triangle. From the popliteal crease, you choose the midpoint of that line and draw a perpendicular line extending 7 to 9 centimeters, and that marks your needle insertion point. Under all aseptic precautions, the skin wheel is raised with a local anesthetic, and a 22 gauge 50 to 80 millimeter short bevel insulated stimulating nerve block needle is used, and the target response should be inversion of plantar flexion of the foot at a currents between 0.3 to 0.5 milliampere. Around 15 to 20 ml of the drug is used. So ideal response includes inversion more than plantar flexion, more than dorsiflexion, more than eversion. Okay. The inversion of foot is caused by the tibial nerve and the deep peroneal nerve, eversion by the superficial peroneal nerve, plantar flexion by the tibial nerve, and the dorsiflexion by the deep peroneal nerve. Since inversion of foot involves both the nerves, that is considered to be the most ideal response for a popliteal sciatic block. Here, as you can see, the patient is positioned in prone position and the landmarks are marked with a pen. So there is the popliteal crease, the tendons of both biceps femoris and semimembranosus, semitendinosus, and the needle insertion point is around 7 to 9 centimeters at the midpoint of that line. Okay, as the needle is inserted perpendicularly, we have to look for the movement of the calf muscles or the flexion and the inversion of the foot. As you can see the plantar flexion of the foot. Once you see the response, you reduce the current to less than 0.3, and you have to see that the response is gone at less than 0.3. Once you confirm, then you can start injecting the drug. So troubleshooting for the popliteal sciatic block. Here, if you see the local twitches of the biceps muscle, that means there is direct stimulation, the needle is too lateral. You withdraw and redirect medially. Same with semimembranosus or semitendinosus tendon, that means the needle is too medial, you redirect laterally. If you see twitches of the calf muscles without foot movement, that means the smaller branches of the muscular branches of the sciatic nerve is stimulated, and you have to disregard this and continue advancing the needle till you see a foot or the toe movements. If you contact bone, that means your needle has gone too deep and hit the femur. So either you missed the nerve completely or the motor response was not appreciated. You withdraw slowly and look for the twitch. Coming to the lateral approach for the popliteal sciatic block, again here patient is positioned in supine position and the foot to be blocked should be positioned so that even the slight movement of the toes can be seen. Best achieved by keeping the foot on a footrest. The anatomic landmarks include the popliteal fossa crease, the tendon of the vastus lateralis, tendon of biceps femoris, and the needle insertion site is marked in the groove between these two tendons at around 8 centimeters proximal to the popliteal crease. Under all aseptic precautions, a wheel of local anesthetic is raised, and then a 10 centimeter 22 gauge needle is inserted in the horizontal plane between the two tendons, and it is advanced to contact the bone first. Once it hits the femur, you withdraw the needle slightly and redirect 30-degree posterior to the previous angle, and you keep advancing till you see the twitches. Here, if you see the twitch of the biceps femoris muscle, it is due to direct stimulation. That means your needle is too narrow and too shallow. You have to keep moving forward. If you see vastus lateralis muscle, the needle is too anterior and you have to withdraw it and redirect it more posteriorly. The twitch of the calf muscle, again, that means the smaller branches are stimulated. You disregard and continue advancing the needle to see a foot or the toe twitches. If the foot or toe twitches is obtained, that is the ideal response. Best response is inversion. Like we said before, you accept and inject the local anesthetic. The complications of popliteal sciatic block include vascular puncture, nerve injury, infections, delayed recovery, pressure necrosis of the heel, and delayed detection of the compartment syndrome. To all these patients, you have to very specifically mention that the action of your block is going to go on for much further than the surgery itself, and they have to be careful while they are ambulating. Always advise them to walk with support. Coming to the obturator nerve. Obturator nerve arises from the anterior division of the anterior primary rami of L2 to L4. It descends medially along the psoas muscle, lies superficial to the obturator externus and deep to the pectineus, and then it bifurcates into anterior and posterior branches and exits to the thigh through the obturator foramen. It provides anesthesia. It provides innervation to the adductor muscles, cutaneous innervation to the medial aspect of thigh, which is highly variable, and it provides articular branches to the medial part of knee joint and hip joint. Indications include for the relief of adductor muscle spasm associated with hemiplegia or paraplegia, and to suppress the obturator reflex during a TURBT surgery. Contraindications include patient refusal, inguinal lymphadenopathy, perineal infections or hematoma at the site of needle insertion, and coagulopathy. Equipments, you need a nerve stimulator, you need an insulated stimulating needle 5 to 8 centimeters, and local anesthetic around 10 to 20 ml volume. So for the classic Labarthe technique, patient is positioned supine with the limb to be blocked at 30-degree abduction. Pubic tubercle is palpated, and then a 1.5 centimeter line is drawn laterally and downwards. And the injection site is labeled at the tip of the end of the caudal line. Again, after giving a local injection, a 22 gauge 8 centimeter long needle, the skin is penetrated perpendicularly and the needle is advanced until it contacts the inferior part of the superior pubic rami. It usually happens at a depth of 2 to 4 centimeters. After contacting the pubic rami, it is redirected 45 degrees laterally into the obturator foramen for another 2 to 3 centimeters to see contractions of the adductors. The evaluation of obturator nerve block is a little tricky. The evaluation by sensory testing is unreliable because there is highly variable sensory innervation from the obturator nerve. In some cases, obturator nerve may not have any sensory branches that can be clinically tested. So, the strength of the lower limb adductors relies 70% on the obturator nerve. So, if there is a reduction in the strength of the adductors of the thigh, that is the most reliable sign of a successful obturator nerve block. The incidence of complications in obturator nerve blocks is relatively less. That could be because of the amount performed is lesser compared to the other nerve blocks. The complications include unintentional intravascular injection and hematoma formation. And since the needle is directed into the pelvic cavity, they can penetrate the pelvic cavity and perforate the pelvic organs like bladder, rectum, and spermatogoid. That's all for today. Thank you.